Initially, we had some experience just that the effects of neoadjuvant treatment, radiation, chemotherapy, which has been going on for decades. We've noticed that some tumors responded very well to the point that we couldn't quite see them. So I think faced with that kind of, opposition sometimes from patients, and we didn't know what the significance of it was, that's the reason why we opted to allow some patients not to do surgery. There's been some experience with this initially with a surgeon, Dr. Habergama from Brazil, was one of the first people to actually look at this extensively. And that was in the 2000s. And she was able to show that it is a reasonable option for some people who are, again, concerned about some of the outcomes that we just discussed. It's still not by any means considered a standard of care or the best option oncologically. So I think there is some concern across many colorectal practices whether or not this is something we should even be doing. It's certainly been published on by some high volume centers such as in Memorial and elsewhere within America. So we basically wanted to see how it would happen for our patients. Initially, like I said, we started off not necessarily with the study in mind, but rather some excellent results in patients, and we're looking at basically no evidence of any residual tumor. So we started offering this watch and wait approach to patients who met the strict criteria that Dr. Habergama first laid out back in the 2000s. And we're able to show that we had pretty good results, even within a large integrated practice that spans both a tertiary medical center as well as community type practices. We're very careful about who we pick. They have to meet the strict criteria. And then, one phrase I've learned to really understand in the last few years is shared decision making. I think in the past, oftentimes a physician or surgeon would simply give what they think is the best answer and expect the patient to follow it. I think a watch and wait is probably the epitome of having that shared decision making between yourself, the patient, and also there will be medical oncology and radiation oncology involved as well. So it's kind of like a group decision as far as what may be the best for the patient and give them what the risk benefits are for each approach. And then the patient could select watch and wait if they're lucky enough to meet that strict criteria.
When I counsel patients on before they start neoadjuvant concurrent chemoradiation, I will mention the possibility of a complete response. And I'm careful to point out that it's a minority of patients who are lucky enough to achieve it. And at the point that we reassess them, and if they do have a complete response, we certainly take into consideration the whole patient, and it is a shared decision-making process, as Dr. Adaluri referred to. And I think we emphasize to patients that it's an experimental approach, and that there is we do expect some risk-benefit trade-off, and the thing that we've shown with our study is that with careful surveillance and early intervention, it does seem to be generally safe.